Hello, everyone. Welcome to Teddy Talks, a podcast created by UCL Paediatric Society, where medicine meets mischief and we discuss all things pediatrics, from teddies to training pathways. I'm Yamina, one of your co-hosts, and I'm currently in my first year of medical school.
And I'm Letitia, your other co-host and a fourth-year medical student. We're so excited to finally be able to launch this project and explore pediatrics together. Each episode will be breaking down the wild world through stories from the wards, chats with doctors who have loads of experience in the field, and have honest conversations about the future of pediatrics. Whether you're a medical student, aspiring medic, or just here for the baby giggles and interesting cases, you're in the right place. We hope you're as excited as we are.
Today on our very first episode, I should say, we're diving into a real hot topic in pediatric healthcare, which is adolescent psychiatry. To do that, we are super excited to invite Dr. Simon Lewis to the podcast. Dr. Lewis is a consultant child and adolescent psychiatrist at UCLH and has been working with children, young people and families for most of his medical career. And he's also the lead for the Bodymind faculty at the College of Medicine, emphasizing the integration of mental and physical health in medical practice. His research interests lie within parental-child relationships and the connection between physical health and their psychological repercussions. Alongside his work as a psychiatrist, Dr. Lewis is a trustee for Global Generation, a charity focused on youth development and environmental sustainability, and a collaborator on The Cards, an initiative that promotes collaborative and compassionate approaches in healthcare. So it is an honour to welcome Dr. Lewis to the show. Thank you so much for being here.
Thank you very much for having me. I think I feel more honoured to be here than you should be honoured to have me, to be honest. It's really important, I think, that people at my stage of the career, which is perhaps towards the end, have the opportunity to actually have conversations with people at different stages. So I'm really delighted to be here. Thank you for inviting me.
Oh, we're so glad to hear that. So just to start, give us a second. We'd love to start to just talk about that journey itself. We know what got you to where you are today. So why adolescent psychiatry? What was the training pathway like to get you to where you are today?
So I'm going to answer that in a fairly, not too long-winded way, I hope, but I'm going to try and pull together kind of content things that might be of interest and useful, but things you can find out, but also something more about my story, because I think narratives and stories are part of what it is to be an embodied human and are actually really important. And, you don't know me and the people watching don't know me, so you're going to have to accept that what I'm about to say is not about ego. Just bear with me, you'll see. Don't switch off quite yet. So, I'm very successful and I had awards and senior consultant in a teaching hospital and all that kind of stuff. But it took me 4 goes to get into medical school. And I think that links to why I'm an adolescent psychiatrist. So I went to a very good school and I was in the medics kind of A-level group. And all my friends went to medical school. One went to vet school. Most of them went to Oxford or Cambridge. But I ended up going to a cramming college in King's Cross, which wasn't really the aim. And I won't say too much about why, other than I didn't do any work and I was more interested in other things, which were fine to be interested in, but didn't tend to help you pass your A-levels. And so I really did very badly. And I think at the time, my family, I was lucky I was from a family that still believed in me, but I was told, you won't make it. That's it. You've blown your chance. You're not going to get into medicine. You're clearly not up to it. And I felt really distressed by that. And it was about something to do with where I was at developmentally. I wasn't behind or in front. I wasn't right or wrong. I was just where I was at. So my friends knew how to work and they got on and off they went, and I didn't. And I think that rather than praising them or condemning me or others, there's something about adolescence, this period of time, maybe from 13 to 25, something like that, that, I wasn't interested in it at the time objectively, but looking back, it is of significant interest given what happened. So I struggled and I went into the degree in biochemistry at Imperial, which was not what I wanted to do. And I was pretty miserable and really found things very tough. And then I developed at the rate that I was going to develop at and did well and then had offers to medical school and got in. And I think it's worth saying that because without naming names, there were some quite significant people in the medical hierarchy who my family knew who basically said, don't bother. And I was a bit kind of bloody minded and thought, well, I want to do this, so I'm going to keep trying. And I got there. So that's why I'm not being egotistical when I say I've been successful. Really important that at that stage we don't write people off.
Yeah.
Therefore, you could see why, when I then go through medicine, and, I love being a doctor. I'm very proud to be a doctor. And I did a cardiology job at King's and really enjoyed putting in central lines and all that kind of stuff. But for me, and it's all about individual journeys, given there are 150, 200 careers or whatever in medicine, I don't know, that for me, that bit became not that exciting. And what the challenge was, I remember that being on coronary care at King's in the middle of the night, running it as an SHO, which is a bit ridiculous. The challenge was sitting, talking to the wife of a man who was about to die. And that was really distressing and difficult. That, for me, became more of a challenge and more kind of curious to me than following protocols and getting the INR right, which was just as important. I'm not saying it wasn't. And so then I think I ended up then being pulled towards psychiatry. And then I'm a child and adolescent psychiatrist, but within that, I think adolescent psychiatry is something really fascinating. I can say a bit more about that when we talk about adolescence, maybe. I hope that explains something about how I got to be a child and adolescent psychiatrist. And then training wise, it was about choices of the kind of training you want. That's still the case. There are different places, in London, but all around the country, where the trainings, of course, they have to cover the core, absolutely, whatever that includes, psychosis, depression, affective disorders, neurodevelopmental problems and all of that. But there are different emphasis in different training schemes. And I trained at the Tavistock because I was particularly interested in advanced psychiatry training, but also in psychodynamic and systemic family ways of thinking. Does that kind of give you a bit of a answer?
That's absolutely great. Absolutely.
Yeah. That was really interesting to find out all about where you started off from and how that inspired you actually to become a adolescent psychiatrist. And we were also just wondering what an adolescent psychiatrist actually does. Like, what would your average week look like?
Yeah, that's a really, really good question. In fact, I would say that any doctor, medical student looking for a job, find out what your week actually looks like and where you'll be, and will you have a desk? And these things are as important as, I'm going to be doing hematology. Okay, well, where, how, who with, and all that stuff. So I work part-time in the NHS now. I was full-time until 2021. And so I'll talk about that period of time. So for 21 years as a consultant from 2000, ran an adolescent psychiatric unit and worked in paediatric liaison at UCLH, which is the bit you're perhaps a bit more interested in. But I think as an adolescent psychiatrist, there are a number of different places you can work. I think you can work on a paediatric ward doing liaison, where we're kind of trying to marry body-mind. Or you can work in the community, seeing young people who are referred by their GPs. Or you might even work within school settings or other settings. Or at the kind of harder end, whatever that means, you can work in an inpatient setting, which I did as well. So there's quite a lot of variety, even within child and adolescent psychiatry, in terms of what you can do. Some people subspecialize in forensic, for example, not something I did, and become forensic adolescent psychiatrists. There are a handful of those across the country. So lots of different possibilities. In terms of what the week looks like for me, and I'll talk about it as if I was full-time at UCLH doing paediatric liaison. So it's a mixture of, obviously, a number of multidisciplinary team meetings, which is great, where you get together with your paediatric colleagues and with paediatric nurses, mental health nurses, occupational therapists, physiotherapists, psychologists, psychotherapists, social workers. I've probably left someone out, I'm sorry. But a vast array of people with different expertise, where coming together to really think about complex young people who present often with years of difficult challenges or adverse child experiences earlier on. You need that team really to really add to the kind of thinking in terms of formulation and trying to work out what's going on, but which of course informs your investigations and management plan. So I think there are a number of multidisciplinary team meetings on the paediatric ward, on the adolescent medicine ward. Then we have our individual meetings where we might meet with psychiatrists, psychologists, psychotherapists, social worker and mental health nurses to think about our cases and really go into depth about what's going on, which is often very difficult and quite painful. There can be quite a lot of uncertainty, but that's part of the deal of the profession that I'm in. And then there's seeing young people, of course, and their families. So we look after young people who present in the emergency department. So they might have come in with some form of self-harm or overdose or very low or high risk, or more recently, quite a few young people coming in with psychotic presentations, which need to be thought about very carefully because, of course, there are lots of causes for psychosis, which is not a diagnosis, it's a symptom. So we cover the emergency department. Although there are layers beneath me, as I don't mean that in a rude way, but as a consultant, if one of my fantastic senior nursing colleagues says, Simon, please come down, I don't question it. It's like, if she wants me to come down, I hope I'm going to be able to help, because it's going to be pretty complex. I think there's quite a lot of sort of wayfinding, which is not some unknown, really. It is unknown, but it's based upon experience and assessment and thinking, and sometimes recognizing you can't get the answer straight away. So just, I don't know, a silly bit of the story of my stories. I did an orthopedic house job, which I loved, and it was brilliant and really good fun. And I was allowed, obviously with lots of supervision, to put in a dynamic hip screw, and this very elderly woman couldn't walk, and then she could, and it was brilliant. And, child and adolescent psychiatry is not like that. Very, very rarely is it straightforward, but it is therefore very interesting, very challenging, and very rewarding if you're willing and able to really engage with young people and their families. And you have to engage with their families as well. And then we have outpatient clinics as well, where we will, particularly at UCLH, we've got a lot of specialist services, got sort of rehabilitation services for young people with very complex medically unknown symptoms. That's not a great phrase, but we still use it a bit. And kind of highly complex young people with diabetes and rheumatological problems. And of course, there's a very big cancer centre for young people as well. So we cover quite a lot of specialties as well as the emergency presentations. So it's quite varied. And of course, there's lots of teaching linked to UCL and lots of supervision of the CTs and STs coming through, which is a joy and really, really good fun. I think the other good thing is that often when I look around, child and adolescent sort of mental health teams, which is not just unidisciplinary, they're pretty motivated, bright, kind of quite nice people. Don't tell my colleagues I was nice to them about them rather. But, and actually that's really important, isn't it? To find your tribe within medicine where you fit. And I'm not saying where that should be for the two of you or anyone else. You need to find that. So very varied week, very interesting. Still lots of coalface or frontline work or whatever term you want to use, which is really appealing to me. Did all kinds of medical management when I ran the inpatient unit, but never wanted to be a medical manager and go up that line. I get why that's important, but that wasn't for me. I feel like I've been quite well paid, very highly trained to look after young people, and that's what I'm hopefully reasonably good at.
Perfect. That links quite nicely actually to my next question. I think often when we think of paediatrics, we think of, colourfully decorated children's departments, and we think of the use of play and fun and practice. I would say that adolescents are often overlooked, as they don't tend to be the group that most of us at least immediately think of when we're talking about paediatrics. And you spoke about this idea of the role being particularly rewarding, and I was wondering, what is the most rewarding thing about working specifically with adolescents?
That's a really good question, and I'm going to answer it in reverse by saying why people wouldn't think it was rewarding, and then I promise you I'll answer your question. Okay. I have two children. They are now young adults, so I went through adolescence with them. I might say something about that. And I've spent the last sort of 25, 30 years with young people, and they drive us mad. And I'm sure the two of you were delightful adolescents in the families or wherever you grew up. I'm sure you never caused any difficulty to your parents or carers or whoever you I'm sure you were always delightful. Isn't that right?
Absolutely.
Lying is very naughty. Maybe you're thinking, actually, I was really good, and that's fine. Of course, there's a big kind of distribution in terms of what's appropriate culturally within your family culture, based upon all kinds of factors that we don't need to go into now. So what's right in my family culture wouldn't be right in yours, and vice versa. As long as it's legal and nurturing, it's fine. So adolescents are quite difficult, and adolescents who have mental health diagnoses or challenges are often particularly difficult. And that bit, I'm not going to lie, can be very hard to manage. We were in our MDT yesterday, and we were told about a young person who said they hadn't harmed themselves, and then we had to look at pictures, and it was clear that they had. I'm not going to go into the detail, it would be appropriate, but not particularly pleasant. And as a side story, I'll share with you, I've been a consultant nearly 25 years in a couple of weeks, it'll be 25 years, that I'm pleased that when I see those pictures, I don't like it. I don't mean that I collapse and cry and run out of the room. I don't. But I'm pleased that I don't like it. I'm pleased that I'm not immune to it through habituation. It's actually part of the work in terms of maintaining that ability to engage enough, but not so much that you can't sleep at night and you're crying all the time. I don't mean I never get upset. Of course I do. So they're very difficult. Now, to answer your question, they're difficult for all kinds of reasons, and they're difficult in terms of how people see them because things are changing. And I give a whole talk about this, I mean, if I'm still working at UCL in a few years, you will have the pleasure of hearing, which is about, the opportunity of adolescence. It's something I'm a bit obsessed with. It ties into the story I told you about my own adolescent journey. And there are so many changes happening in the adolescent brain, with grey matter pruning, white matter being laid down, dopamine sensitivity going up. So you can see I'm interested in all different levels. And someone described it brilliantly in a book I read once, which is that in adolescence, the accelerator, the foot on the accelerator in terms of pleasure, risk, trying things, is flat on the floor. Okay, so we're going full speed. The brake is a bit rubbish. And the brake in our human brains is the prefrontal cortex, where we learn about not doing things that are dangerous. But when we look at studies, the prefrontal cortex in young people is a bit pathetic, which kind of makes sense if you're designing a species where you want adolescents to go off and procreate and try things and move away from their families. But here's the really big thing. All of this brain change means that for that young person who's had those adverse child experiences, those horrible traumas, if we can do the right kind of work with them and their family and their environment, so it's not just about, a psychiatrist or psychologist or nurse doing something. If we really think about them broadly, you can actually make quite significant changes because their brains have more plasticity than mine. It's not that at my advanced age, I don't have any ability to learn. I do, but not like you guys. And I'm guessing you're in your early 20s and your brains are still developing and changing more than mine is. And that is what's exciting about working with young people. And a bit like my own story, written off, told you won't achieve anything. Okay, I developed a bit later. I can assure you when I went to Imperial, that is not a laugh going to Imperial, I can tell you, it's so hard work. I suddenly discovered, this is what work is about. Okay, and I was in the library for a year to get a good degree to get into medical school. So, and about hard work. You're just beginning to know about hard work as a first year.
Yeah.
Letitia, you know about it more. But you obviously work very hard to get here. So I think being able to do that work at this very pivotal time that was even described by Shakespeare in A Winter's Tale, where he talks about, I wish there was no age between 16 and 23. And basically what he's saying is, and it's a joke in A Winter's Tale, is between 16 and 23, young people, all they do is they're horrible to old people. They get girls pregnant, they fight, they steal, they're difficult. I'm not suggesting those things are okay. But it was recognized even then, that this period of adolescence, is quite challenging, but that's because of all the change happening. So if we get in there with someone who is significantly depressed, say, because of trauma or whatever's happened to them, and we really treat them well, and I mean treat them well in every way, in terms of engaging, being warm, being compassionate, and providing evidence-based treatments, it's not either or, and we help them shift their trajectory, then it's quite possible that in adulthood they won't get recurrent depression. We know that when we don't treat depression in young people in adolescence, for example, and that can relate to their paediatric difficulties. I can assure you I look after people with diabetes, I look after people with rheumatological conditions, and I did the psych-oncology job for a bit in my time at UCLH. If you can get in there and do something, you can help people onto a better trajectory. There's more plasticity, more possibility for change. And that's really exciting.
I think, again, that quite links well to the next question. As you've said about how there are long-term effects with the plasticity of, sorry, let me start over again. Considering that there are long-term effects of psychiatry and the psychological aspects of, especially in this very crucial period of time in the adult and on their personal development and their cognitive development in the future, how does adolescent psychiatry differ from adult psychiatry? Well,
in a way, I think you've answered the question, because it's about taking perhaps a more developmental approach. Now, I think that's coming into adult psychiatry a bit. I won't talk too much about this, but just touch on it in that, for example, adult ADHD, which is quite a contentious issue. Is it overdiagnosed? Is it underdiagnosed? Was it not recognized anyway? I won't go into that. But so adult psychiatrists are beginning to get more interested in developmental processes. Generally speaking, and this is not putting down adult psychiatrists at all, that they aren't trained in developmental approaches, whereas, my training, taking a developmental approach, and I don't just mean taking a history where you learn a few questions, but really understanding something about early development and development through childhood and adolescence, allows you then to hone your history and mental state exam to discover what you need to understand something about why they are presenting now, why they are where they're at now, what's really happened to them. So I think that, yes, it's about that developmental approach. I think that's the big difference for a child and adolescent psychiatrist and a paediatrician. When you do paediatrics as a medical student, the first thing you do is really you take a kind of general medical history and you add in the pediatric bit, which is another 10 or 15 questions, something like that. But really, once you become a pediatrician, and obviously I work hand in hand with some fantastic pediatricians at UCLH, child and adolescent and across the board, you can see them taking that real developmental approach. And so things like assessing them across the board is just taken for granted. It's taken for granted that you would ask about their social history in depth and their family history in depth and want to understand something about their early development. Not just the milestones, which are really important, because clearly Johnny didn't walk till he was 4. Okay, that's, that isn't normal. We need to understand why. I don't know why Johnny didn't walk till he was 4, and Martha didn't say anything till she was 6, and now she's only got 4 words. Clearly, these are way outside a normal distribution. So I think learning about that approach, and I think that at the Tavistock where I trained, I did something called an infant observation for over a year, where every week from about the age of 4 weeks, I went to sit and just observe a mum with a baby, and then had to write it up, and then went to a supervision about it. These are experiences that I think a child and adolescent psychiatrist will have, who's done particular trainings that an adult psychiatrist won't have. And in paediatrics, of course, although you might not do that training, you're just spending your whole life with little ones across the board. And in a district general, maybe not at UCLH, although of course it's a general hospital as well, as a paediatrician, I'm going to make this up, but 95% of kids come in for a day and then they're out. They come in really ill with their parents understandably extremely worried and upset, and then they just recover with their drip or their oxygen or whatever they're treated with, a bit of antibiotic, and they're out again. Pediatricians are very experienced in understanding developmentally what's normal and not. And of course, community pediatrics, which pediatric trainees have to do, is going to be all about developmental checks and milestones and things like that. So it's a developmental approach, which I think allows for a richer understanding of an adolescent, a young person. So you often have to, you're with a slightly grumpy 16-year-old, and you have to kind of get past that, and you have to explain why I'm going to ask you about when you were young. What's that got to do with it? Why am I going to tell you that? You don't have to, but I'm really interested in understanding all about you. And that context can be very helpful to think about why you are where you're at.
I think that's also, this links actually to the next kind of conversation we're going to have a bit. But before we move on to that, I wanted to ask, we've spoken about adolescence being a bit of an overlooked group, but I feel like psychiatry almost falls into that as well. Not in the sense that it's less reputable than other specialties, but more that I think sometimes, from the medical student perspective, I think when we have conversations about psychiatry, sometimes it almost seems that people talk about the specialty as if it's less biological or it's not as concrete as other specialties are. And I feel like mental health is often the center of many of our conversations, if not all of our conversations. However, I think sometimes in practice it just does feel a bit overlooked. So I know that you're clearly passionate about the intersection of physical and mental health. So could you answer why it's so crucial to take that psychological side of care just as seriously as the physical?
Yeah, of course. I can try and answer, but I might just turn it around a little bit, because, let me answer a few things. So I think psychiatry is seen as being less reputable. I think that's just a truth. And I think there are a number of reasons for that. I think it has been seen as an easier profession to kind of advance in. I'm not sure that's true anymore. And I think there's also a lot of fear from people who are not interested in the mind, whatever that means, about the mind. That can lead to some prejudice. I think that you see similar things happening in general practice. I know absolutely brilliant GPs who are probably the best doctors I know, and I mean across the piece. There are some who aren't, but that's true in all specialties. So I think psychiatry does carry a certain rap with it. I think what's interesting is, and you've used the word intersection, is that I kind of play a trick on my medical students, and we're going around the country at the moment doing a bit of trying to do some kind of interaction with medical students. We went to Leeds a few weeks ago, and we are planning to go to some other places. And one of the tricks that I do, and I'm going to do it on you now, so I'm so sorry, is I try to come across, I hope I do come across as warm and engaging and interested. Of course, you have to nod. You can't go no. But let's assume you're telling the truth again, Yamina, rather than about your adolescence. Yeah. So warm, engaging, seems thoughtful. And then I say, okay, Yamina and Letitia, are the body and mind connected? So I'm asking you a question in this podcast. Yamina, are the body and mind connected?
Yes.
Thank you. Letitia, are they connected?
Yeah, I think so.
Okay, that's really nice. That's really helpful. Would one of you mind asking me that question?
Are the body and mind connected?
No. So I say no, and you feel uncomfortable and think, okay, but he seemed okay. And your brain's rattling through lots of thoughts like, shall we cut this bit? And how on earth do we begin to explain this? But then, and I want, like a good movie, I want you to feel anxious to a point, but then I'll bring you back down. It's okay. And the reason why I don't think they're connected, and I genuinely don't think they're connected, is they're one thing. They're not connected. Oh, okay. Yeah, there you go. They are. So here I am. We're on a screen. Hello. I'm embodied. I'm one thing. Okay. And you only need to look at the simplest example of, and I don't mean, a cold, but if one of you had flu, you're not going to die. You feel really ill. And actually, after 2 days, even though you're told by a family member or someone who loves you, you'll be okay, you think, well, this is going on forever. How will I ever recover? And then after 5 days, you're still really tired. You think, I'll never get my energy back. And you start worrying about it. So even that mild anxiety, it might be moderate anxiety, is completely, it's not linked to one thing. And similarly, the physical sequelae of psychological problems. I mean, here's the problem. Hear my language. My language separates them. So this goes back, really, in terms of explaining something about this part of our discussion. This goes back to a problem in the West, I'm calling the UK the West, where Descartes, who was a French philosopher and mathematician, gets blamed for this. It's not just him. This separation of body and mind, really, started probably, I don't know, in the 16th century, maybe at another time. And if you go to the East, and I mean east of here, or Southeast Asia or somewhere like that, or Japan, there's a whole different language around this, that we don't have the same words. There's a word for sort of body, mind, soul, spirit. It's one word in Japanese. Don't ask me to pronounce it. I can't do that. And and similarly in India and that part of the world, different ways of thinking. I'm not saying they're right or wrong. I'm not criticizing anyone. I'm just saying we don't have the language, and actually our medical language is completely separating the two, and it's not helpful, because as you've already noticed in your time at medical school, the idea that someone coming to a clinic with a potential, cancer isn't going to be anxious, I mean, is pretty unlikely. And how you manage that as a good clinician is so important. Can I carry on talking about this? Is that so? I'm going to say something a little bit personal, but not too personal, about certain experiences. So, I'm a doctor, but I've been a patient. You've probably both been patients or will be at some point. So the difference between doctors and patients isn't really quite as big as we might like to think sometimes. We can kind of hide behind our stethoscopes, but really it's not. It's only a matter of time, probably. I don't mean that negatively. Here's my view of medicine. At some point we're all going to not be here anymore. And, there's a sadness to that. We have different cultural and religious beliefs around that, and that's fine. But here's the thing. I'm not hoping I don't die in 3 weeks. That's not the plan. I've not been told that. But let's say I suddenly got stage 4 pancreatic cancer tomorrow. Again, not my plan, but who knows? How that's managed is going to affect how I cope with the next month or two that I have left. I don't want to be lied to. Oh, it'll be fine. No, it won't. But similarly, I don't want a doctor or a nurse to make no eye contact, for me to just be another number on their outpatient list. I want them to engage enough and be compassionate that even when they say to me, look, this is difficult and we don't have any more treatment, but we can do this and we can help with the pain and we can do this. And to really be present, to be embodied, to see me as a body-mind word is going to help me manage that really shocking, sad, surprising, except it isn't really, is it? Fact that we're all kind of mortal. And I'm using a very difficult example, but I think in paediatrics, in psychiatry, to take that approach is really important. That's why I said to you, I'm very proud to be a doctor. I'm not a psychiatrist, but I'm a doctor. I'm a doctor like you are. I've done a resuscitation in the street on someone, and of course I would. I mean, I'm not a high-powered cardiologist or anything like that, but I'm a doctor, and I think that someone in my world, he's no longer with us, but he was kind of very famous in child and adolescent psychiatry. He wrote in a chapter about liaison psychiatry, which is about pediatric liaison. He said, I wish that pediatrics and child psychiatry would come together and get married, if only for the sake of the children. Yeah. And it's a lovely kind of concept, isn't it? And it really is about body-mind. And some of the best bits of consultation work I've done at UCLH have been when I've been in a room with Joe Begent, an adolescent paediatrician, Natalia Zarate-Lopez, adolescent gastroenterologist, and me, maybe a nurse as well. Not all the time, not every meeting, but really thinking together with a young person and their family, where we can all talk together, where there aren't splits where, oh, well, Dr. Begent said it was this, or Dr. Lewis said it was not really very helpful. Why are we splitting the body and mind when they're not separate? They are one thing.
I think that's such an interesting perspective, particularly obviously in our approach in the kind of process of diagnosis and dealing with sickness. But I think also just in that what's it called, that doctor patient dyad in and of itself, and our approach even to ourselves as medical students currently, I think that perspective shifts a lot. I think in regards to our approach, I think currently, as you say, in the West there is this huge division between physical and mental health, and it is interesting to see how can we implement the unity of both rather than an intersection, making them that one frame. I think like my mind's just been blown by the short conversation we've had on that. Do you want to go?
Yeah, I just wanted to add that I feel like in medical school we've been told about, the biopsychosocial model. So we've always been told to think of it as some form of intersection, which is, I guess it's better than a complete distinction, but we've never really thought of it much as the same thing. And I think I read a little bit about as you're head of the Bodymind faculty, is that correct? And the whole premise is that Bodymind is one unity, it's one thing. And we were just wondering if you could tell us a bit more about that. And since to us it's quite a new concept, we were wondering if you've experienced any pushback from having that concept being widened or used in clinical practice more.
So it sounds very grand. I'm the head of the Bodymind faculty. It's not really, but I think it's part of something called the College of Medicine, which is an interesting maverick organisation with people who really want to change things for the better and really care, and particularly care about medical student education. It's not just doctors, but it's mainly led by doctors. And there are some contentious issues around the College of Medicine if you read about it, but I'm not interested in talking about that today. And part of the thing that turned me onto it, I was asked sort of through someone whether I might be interested, and it was a bit of a kind of a sort of dating meeting I went to. It was an online meeting where I was going to see what I thought of them, but they were going to see what they thought of me. I can't believe that, but it's true, and that's fine. So I get into this meeting where I'm probably the youngest person there. Okay, thank you for not laughing too loudly. Okay, so you could be very ageist and think, okay, and there were quite a lot of white people. I have nothing against white people, but there weren't that many non-white people. And that's a bit of an issue. But here's what's really interesting. I'm saying this to kind of play a bit of a game with myself. We're talking, and they said, well, we've got the body-mind kind of group, but we wanted to sort of take it forwards. And the person who'd been leading it, very well, has sort of stepped back. So, we're kind of interested in whether you might be interested. We know that you are a, paediatric liaison psychiatrist, which is all about body mind. And, we hear you're interested in this. And I said, well, I am, but I'd want the hyphen to go straight away, body-mind. And they went, why? I said, well, it's not two things, is it? It's not connected. I said my sort of whole thing I just said to you guys. I said, it's one thing. And the reason why I like the College of Medicine is they went, oh, yeah, okay, then. I was like, oh wow, this was the NHS. Much that I love the NHS, and I work in the NHS and have done for 30 whatever years. It would have been 5 years of form filling. I don't know. It would have been. It's like, no, that makes sense. Yes, okay, we'll call it body, mind, one word. Now, it's all very well me saying, look, this is a great word and it's one thing. You try and use body, mind in a sentence. So you go and see someone on the wards, Letitia, next week. How are you in your body, mind? They'll look at you like you're mad. What's that word? And again, it comes back to our language or lexicon, that trendy word for language, which is that it's not really working for this idea of body mind unity, body mind as one. But that doesn't mean we shouldn't try and change language. And you all know as young people that, even the colloquial languages that you've used at school or uni, changes and shifts, doesn't it? Or he's salty, or it's very good, or I don't know, even those. So words can change, and words do change, and languages are alive when they're used. So my hope is that we can begin to shift the language. But more than that, it's about shifting ideas. So I don't mind if you never use the word again. It doesn't matter. I've realized it's not helpful. I really want to kind of, follow this up by don't try and use the word. And it's not about that oncologist or respiratory physician becoming a psychiatrist. It's about them recognizing the person in the room is a person. They don't have to love them. They might, let's say they're really racist or something, but they're still a person. And to try and be compassionate and engaged and think about them as a whole person. And even if that's saying, oh, I'm so sorry, it sounds like, your COPD is really getting you down, and I'm going to actually listen to that bit as opposed to I'm not listening. I'm just looking at the numbers. Don't look at me. Don't talk to me. right, we'll just increase your inhaled steroid. Thanks very much. Goodbye. Which I've seen happen. That's not medicine. That's not medicine. And actually with AI, which is fantastic, that's definitely not medicine, because what AI is going to do is free us up to be embodied with each other in the room, because that AI can't do yet and isn't going to be able to do for quite a long time. I don't need so much anymore to know the 25th cause of clubbing. I can just ask ChatGPT what it is, not that I need to know that ever. Do you understand what I mean? So I think AI is a great adjunct, but actually what we need to become, and what you need to learn in medical school, I think, and what's so important, whether it's paediatric psychiatry or whatever, is to take that really compassionate body-mind approach to what you're doing with your patients. Because then, here's the thing, this is an odd thing to say, it's very selfish to do this. What do you mean very selfish, Simon? Well, here's why. If I am a really compassionate, kind, thoughtful and intelligent doctor that knows things, it's not just about being kind, but to know stuff as well, I'm really available to you. The consultation is likely to go pretty well. I mean, it might not, but it's more likely to go well. You will leave and say, thank you so much, Simon. I will feel really good about myself. That's really selfish, kind of. Do you get what I'm saying? So being a really good doctor, being really engaged, compassionate, present for your patients, and knowing your subject, which of course you must do, is selfish in the sense that your patients will benefit more and you will feel better about yourself. And I can give you an example of that not working if you want me to. I don't know. So I will give you this example. So one of my daughter's a third year medical student, and she doesn't mind me talking about this. I won't name her particularly, not at UCL. And she had a really large lymph node, like properly large, that just didn't go and was getting bigger. And she was a bit tired, and it wasn't EBV and it wasn't CMV, and her blood count was okay. And it's that interesting thing when I'm married to a GP, we're both doctors, where you don't want to overreact, but you also don't want to kind of underreact and think, oh, well, it's nothing. Anyway, she's an adult anyway, young adult. So in the end, she got referred by a GP, felt it and went, I think we just need to check this. Like you said, I think it is okay, but we just need to check this. Fine. So of course, then you get on a 2-week wait. So then you get letters from cancer centers. That's really fun. And you get endless texts from cancer centers. That's really fun. Anyway, she's fine. But the consultation went something like this, and I won't say where it was. She wanted us to come with her consultant father, and her, partner GP mother was there with her. And, and we're polite and, well, reasonably polite. And we go in and the man doesn't make any eye contact with us, doesn't say hello. I didn't expect a whole conversation, but why not just say, oh, hello, nice to meet you. Are you Amber's parents? Or there we are, names now, it doesn't matter. But nothing. And then almost no eye contact with her. And then, I see you're a medical student. Do you think probably you're over anxious about stuff? Actually, she isn't. But if she was, okay, that needs to be thought about. And you could reassure her by saying, well, let's hear the history and take the history, and then let me examine you and take it from there. And he was sort of really sort of down on this and sort of putting it down the history. And then he examined her, and she's behind a curtain, and I heard him go, because she did have a very large lymph node. So as it happens, it wasn't made up or all in her mind. But even if it was all in her mind, that needs to be contained. It was very unsatisfactory. And I just thought, when we left, and we didn't say anything she didn't want us to, and I didn't complain or anything like that. I could have done. And I could have been, used my powers as a consultant to be really triumphant and put him down. But what was the point in that? It was just very unsatisfactory. And I thought he probably wasn't satisfied. He didn't probably feel very good about it. Don't practice medicine like that. And if you take a body-mind approach, even if you don't use the word, then okay, if someone's anxious, they're anxious. Then, either manage it yourself if you're able to, or get help to manage that. I'm not suggesting everyone's a psychologist or psychiatrist. Of course not. But say, oh, I'm really sorry that this is so hard for you. We see young people with inflammatory bowel disease. They've got real pathology. Of course they have, demonstrable pathology. Most of them are really struggling to eat, because I eat and I get pain, so therefore I don't want to eat. Struggling with their mood, struggling because they get this at 17, 18, which is a horrible time to be having stuff done. Some of them are having surgery and having bits of bowel removed. And it's really, really tough. I think, Yamina, you've just frozen.
I'm back. Can you hear me okay now?
You're back.
Yeah.
So I don't know if that makes any sense or is a helpful digression, but I think it's an example of, I guess, how not to practice medicine. And what I would say to you and all of the medical students is, you'll be in so many different scenarios with different doctors, and you take the bits you like. Wow, she did that beautifully. Wow, I wonder how I can use that. Oh, I don't like how you did that, and I don't want to do that. How you maintain that through your medical career when you're put upon from the minute you qualify, aren't you? We'll tell you where you're going to work. Quite a clever strategy to undermine doctors' professionalism, isn't it? We'll tell you where you're going to go. Hopefully that'll change. it's hard to maintain that. But if you try to kind of keep that insight into your own body mind, think about, well, why do I feel angry today? It's not actually that patient's fault. They've come to see me. They've been waiting to see me. They will hang on every word I use. If I use really negative words, that's going to really impact on them. It's not about not telling the truth or making things all flowery. It's about how you say things. The power of your words to affect the body mind of your patients is really significant.
Absolutely. I think we're going to go for a bit of a shift now. We want to discuss some of your research, but I think this is a question I'm personally quite interested in. And I'm not sure if you've watched the Netflix series Adolescence. We're going to get a bit confused because talking about adolescent psychiatry now, the show has the same name, but it's recently made headlines as it tackles some heavy themes around teenage mental health, identity, and it's clearly had a lot of impact. Netflix has made it available to all secondary schools, I believe, across the UK. And from your professional perspective, how accurately does it reflect real adolescent experiences? Do you think shows like this help or harm young people's understanding of mental health? I know that a lot of your research has been on family dynamics, particularly the relationship between like father and child. So I was wondering if you could expand on your own opinions about this sort of issue and its presentation in the media currently.
Okay, that's a really good question. I have watched it, so that's helpful. It's very helpful.
I know what I would have done otherwise.
What shows? I have watched it. Interestingly, I wasn't going to watch it initially because I didn't know what it was about initially, and I was like, I don't know if you know the phrase "a busman's holiday." It's like I don't watch medical shows because I wasn't going to watch it because I didn't know anything about it. And then a couple of mates said, "Oh, you should really watch this. Why should I watch it?" He said, "Well, first, it's beautifully made, it's incredibly performed, but it does touch on something really challenging." So the first thing I'm going to do is because I like challenging questions. I'm not going to be binary and say it's good or bad. I think that's too easy and doesn't embrace complexity, because undoubtedly someone watching it will be distressed and find it very difficult. But I think many people watching it will gain a real insight into something about what is happening in our world. And that's the bit that's interesting. Now, what's really important is, because the way it was filmed was bonkers, the one-shot wonder of Stephen Graham, and it's incredible. And watching the vids about how it was shot is incredible. But let's just put that to one side. I think that what was clever about how it was written was you don't hear that the young boy, because I know he's a young boy, but he looks so brilliantly cast. Because firstly, he's beautiful, and I know you could say that's terrible. How could you say that thing? But actually, he is an attractive-looking child. And secondly, he's incredibly small. If he was some big hulking nasty, it would be easier to kind of be more, negative about him. So he's cleverly cast. Secondly, he performed it beautifully. But I think that what was really clever was there's not suddenly the typical kind of backstory of he was sexually abused. He's been beaten around the head with a cricket bat every day of his life. He's been deprived. I think there's interesting touches on the relationship with his father and the school, but then how the school meant to react with what happened. So the school is not a normal day at school. It's a bonkers day at school. And I think that his dad is a bit angry. Lots of people are. We don't have any evidence he's been abusive. What's happened in this nuclear family? Where they seem all right. They're kind of getting on. They work. They've got enough money to put food on the table. They've taken away those kind of variables on purpose, I think, because it would be too easy to sort of blame it on some of the very understandably challenging things that people have to go through. In terms of depiction, of course, it's the extreme. This is forensic adolescent psychiatry. And as I said, there are only a handful of forensic adolescent psychiatrists in the country. I think what's clever about it is it's showing how easy it is to be shifted, given the fair horror of these things, and joy, and tickets, and weather reports, and all the great things, and all the terrible things. I think it's a real kind of warning about what's happening to us in terms of humanity and how we're developing. I think we're in an age of popularism. I'm not going to get too political with you. I think we're in an age of things being very binary. You're good, I'm bad, vice versa. Everything we've talked about so far is about embracing complexity, which is really where human beings are at. We've got 80 to 100 billion nerve cells in our heads, trillions of connections. We are really, really complex. We have to be thought about in layered ways. And I think what the program did well was to begin to do that. I can see why some people didn't like it. Lots of people said to me, was the psychologist any good? It's written for TV. Yes and no. There were some things she said I was like, well, I'm not sure why you said that. But it's a TV program. It has to be entertaining. It has to be engaging. I think that this pretty slim, petite young man suddenly becoming enraged, it was very well done. I certainly, in my work in the adolescent unit, where we didn't have forensic cases primarily, but certainly had people who had been, had got forensic records and had been charged with different kind of forms of physical assault, not at that level. I think that was something that was very close to what I've seen in reality, where you think things are going okay and suddenly someone you say something, and I'm not sure I like the word triggering because it's not an obvious thing. I could say something really horrible that would clearly upset everyone, or you could, but just touches on something about control. I think that there's been lots of talk about, the rise of misogyny at a time when, equality and the law around equality, and certainly I can only talk about the UK really, is pretty good. The law is pretty good. I'm not saying it's perfect. And yet we see young men treating young women in very particular ways. I think largely because of this, because we know that on this, I'm not planning to do this. I could go into VPN mode. I could go into kind of, even with my lack of knowledge of this thing, and I could search up murder. I'm not going to do this. And I'm sure within a couple of clicks, I could be watching gruesome horror acts. It's too easy and there's too few restrictions. And I think we are really harming young people. Would that young man have killed that person, that young woman, without the phone? I don't know. Who knows? We can't say. Is adolescence good or bad for the general public and secondary schools? If you made me choose, I could choose not to choose. I would have to choose. It's a good thing because it's starting a conversation. And even if it starts a conversation with some young people who say, I think it was terrible and a horrible depiction, it's really upset me. Well, let's talk about that. So for me, it's not just the program, it's what the follow-up is. So it's fine for our government to say, or Netflix to say, let's get it into secondary schools. But like any intervention, I'm smiling because this is so commonly what happens. Well, we'll do that. Yeah, but you've got to think through the consequences. You've got to have the space then with people who have enough experience. I don't mean psychiatrists necessarily, but teachers who are really experienced of working with young people to be able to hold that conversation. Hold it. Hold it, contain it, not just hold it as the words that are said, to be able to explore it. Because just showing that to a 15-year-old without that conversation is probably not great. So I think it's provoked lots of debate, lots of discussion. I think that's on balance a good thing. But I'm sure, a bit like any drug, if you go to the internet and look up any drug, it saved my life, it cured me of everything.
Yeah.
Did it? Or it made my left ear fall off and I grew a third eye. Did it? So the extremes, I'm not sure I believe any of that. It's pretty good, it can help, but it's got to be used in conjunction with this, this, and this. Oh, that sounds more sensible to me. So I think I'm arguing for grey, the multitude of grey, rather than binary zeros and ones, black and white, because I think those extremes aren't helpful. So in answer to the question, I think Adolescence is a well-made program. I found it entertaining. I don't mean entertaining enjoyable, but definitely compulsive watching. And I think the fact it provokes discussion and thinking is a good thing.
Persuaded me to watch Adolescence now. Yeah. I've watched about half of the first episode, but now I'm hooked to watch the rest tonight. I just wanted to move on now to talk a little bit more about your publications and your research interests, if that's okay.
Sure.
We looked. So we know that you've been involved with a lot of publications through your career, and there were a lot surrounding the relationship between the father and the child and the impact of parental relationships on cognitive development. And as a medical student, sometimes we struggle to find research projects that really interest us. So as a starter, I just wanted to ask, were there any professional or personal experiences that brought you towards this research topic? How did you start being involved in this research area?
All right, let me answer that, but I'm going to just say a couple of things first. I haven't published that many papers, and I am a clinician and not an academic. That doesn't mean I haven't published. I have published a few things. I think that some of it's opportunity, in terms of who you're training with and what you're doing. And so actually, as a medical student, I was very fortunate. My first ever publication was with a lovely consultant psychiatrist, and I was a medical student, and we managed to pull something together because he wanted some legwork done, and so that was quite fun. And that was looking at emergency department presentations. But again, that was because he was there. And I suppose you could say, well, he liked me and I was curious. I think that I think not surprisingly, given I am a father and hoped I would become a father before I was a father. I think given my experience of being parented, which wasn't in any way terrible, but I could see that I wanted to perhaps try to shift something if and when I became a parent myself. You'd have to ask my adult daughters what they think. Hopefully they'd say, you know what? Hopefully they'd say, yeah, he was all right. Because actually, in those few words, if an adult child says that about their parent, they're saying a book of he was all right or she was all right or they were all right. You're saying so much more, because to achieve that is quite something. So I think I was very interested in parenting and parents. And then I was fortunate that when I was training at the Tavistock, there was a professor of psychiatry who was partly in Oxford, partly at the Tavistock, and a project came up and I really went for it with another lovely colleague who was training in Oxford, Professor Alan Stein, and various other people, Professor Penny Leach, people you won't know, but people who have written extensively about infant and child development. And I just thought it was really fascinating and really interesting. And I think if you're going to do a research project, because it does involve work and lots of work, for me, make it something you're actually interested in and or something that's actually relevant and important. So one of the little papers I did with a registrar colleague, who's now a consultant colleague, when I was running the inpatient unit, we just noticed in supervision, we were just chatting, this lovely guy Neil and I, and we're chatting about patients, and I said that he was saying, I better do these bloods again. I said, what's going on with their vitamin Ds? It's bonkers. What's happening? And every single patient we had in the inpatient unit had a very, very low or ultra low vitamin D. And we know how important vitamin D is for all sorts of things. Increasingly important, probably, and how, there's now pretty clear guidance that you should be taking it between October and April, let alone longer. And the darker your skin is, the more you should take it if you live in our, I'm looking at the sky, dreary country, and it's probably important for lots of reasons. And what are the links to, some of the disorders you see in Scotland and vitamin D? Anyway, lots of things like that. So we did a paper and we got it published, and actually it led to some changes in how other inpatient units behave. Great. And that was a little paper. I think the parent-infant stuff was really interesting because it allowed me to, and my colleague, I think I met with about 40 or 50 fathers. So that opportunity, there's a lot of work to meet with 40 or 50 fathers over, quite a period of time and spend a good hour and a half with them. It was fascinating. And what was nice was we did a quantitative but also qualitative approach. Don't get me wrong, numbers are great. Numbers really matter, but stories matter too. It's not either or. And so a couple of the papers we published, which you don't need to read, or you may have looked at the titles, around this concept of primary caregiving fathers, because, still mainly mothers are the primary carers. We were curious about fathers where they were the primary caregivers. And actually what we discovered, kind of in a nutshell, was the majority were primary caregivers because the mother was earning more money or the fathers weren't working. But there were a very few, maybe 2 or 3 of our 100, where there was something very interesting in the relationship. These were couples who were together and seemed happy enough, where the father was very clear, I want to be really involved in the care and bringing up my little infant. And often it was because they had not had that. But sometimes there were primary caregiving fathers who were sitting watching the equivalent of Netflix all day and not really interacting with their children. So there's something about some of the research. But yeah, I haven't published massively. If I was an academic, I'd have hundreds of papers, but I'm very happy not to. So I think it's about so as medical students, maybe not in your first year, although maybe, you're on a firm, you get chatting. This is why this has happened. There were a couple of medical students who came to us at UCLH for a week, and I think I got talking with them and they knew you, or I don't know, and put you in touch. And so look, now we're here. This is how things happen. And if after this, either of you are interested in the Bodymind stuff or doing some more, you email me and we have a think. That's how it works, and that's how it should work. So certainly some of the good projects that I've done with medical students have been because they've been curious and interested and wanted to do more.
Absolutely. So this is actually going to be our final question. The time has absolutely flown, but I really just wanted to end by talking about, yes, we've spoken about your role as a psychiatrist, as a clinician, but I think one thing, I've only been at medical school for less than maybe the last 6-ish months, but I think one thing about medicine is that many medics, we often tend to define ourselves by our lives within medicine. Not to say that's a bad thing. From our discussion today, we can see that you've been involved in so many things within the Bodymind, within education. Also, I'd love to talk about the cards briefly if you have the time. I think, what advice do you have for those who want to achieve that sort of multifaceted sort of career?
Well, I think it's an interesting one because paradoxically, I think that you have to remember I'm a bit older than you. that the facets open up more, I think, as you get a bit more experienced. So in a funny way, paradoxically, I'm going to say that it's very important that you really focus on what you want to do within medicine and become really good at that. You know, you're going to be an ophthalmic surgeon. I'm not saying you're going to be that at all. If I don't know, you're going to become an oncologist, who knows, or an old age psychiatrist. I don't know. It doesn't matter. I don't mean that rudely. It doesn't matter. Of course it matters. You'll find your area, and then it's not necessarily the 10,000 hour thing where you have to do 10,000 hours to be good at it, but I think it is about being really committed to that. So there's no, I'm not famous or anything. There's no blue plaque going up about me. I don't want that, but I know and genuinely believe that I've done my best to try to help many young people have better lives. And that makes me feel that my career has been worthwhile. As a consequence of that, because I think, the early years in medicine, F years, and then CT, and where you really need to be committed. But as a consequence of that, if you're open and you're warm and people want to spend time with you, conversations start and things happen, and you become known as someone who's open and available. And whether that's because you're an academic and so you do well that way, or you're a kind of frontline clinician, and please, some of you become frontline clinicians. Not everyone can just do medical education and academia. We do need people to see patients.
Yeah.
I think things begin to open up if you're open to them. So I can say something about the cards if you want me to. I don't know if that's...
Of course.
So the cards, www.thecards.org. I'm going to try and summarize this very briefly. So primarily this came from my wife, Jane. Jane is a GP. She's just finished clinical practice, but is doing tons of other things. And what's interesting about it is a bit like my interest in adolescent psychiatry, but there are frequently silver linings to difficult things, aren't there? And even, I hope you haven't had too many difficult experiences, but sometimes, even COVID, which was horrific, that there were some positives that came from that. And I don't in any way saying I wish that upon the world. Of course I did not. And I think that at a time about 2.5 years ago for our family, something quite difficult happened, and it doesn't matter what that was, really quite challenging. And Jane, as a GP, had been doing drawings and having conversations and developing her narratives. So when you ask about being multifaceted, your narratives, your stories that you tell the people you work with and you tell yourself, develop through all the experiences you have and become honed. And so there are lots of different stories I use when I'm working with young people, which I repeat, and they develop and they change a bit like language changes, but they've been honed over time. And so Jane started thinking about this and started doing some drawings of different things. And then I looked at them and we talked about them. And she said, I think do I write a book? And I said, well, everyone writes a book. Not everyone. Nothing wrong with writing a book, write a book. But I said, but what is this for? She said, well, I think it's something about wanting to share our experience, because between us, we've got 65 years of frontline NHS experience, which is quite a lot. And as a GP and psychiatrist, it's kind of quite a good combination in a way. And so she started doing more and more drawings. And then I think I said, but how are you going to share this? She said, well, we could just do a deck of these drawings with some words on. And I said something like, well, why don't we make them to a pack of playing cards? Because everyone's got playing cards. And then we learned about the symbolism of playing cards, which you probably don't know because I didn't. But it's so obvious when you look at them. And probably you've got a pack of playing cards in your home, and maybe not your student home, but your home, wherever that is. And you've probably played cards in your life. And even though you're on your phone and on your iPad, you might still occasionally pick up a pack of cards, or people do. They've been around for over 1,000 years. And there are 52 cards in a pack, which corresponds to the number of weeks in a year. And there are 12 cards in each suit, which corresponds to... No, there are 13 cards in each suit, which corresponds to the lunar months in the year. And there are 12 royal cards, which is the months of the year. And they are black and red, yin, yang, day, night. So there's lots of symbolism. And because people have got playing cards, Jane worked with an artist and then I joined to think, well, how could we pull in the ideas we think are important from our experience and our learning and our thousands of contacts with people to share something about being human. And for me, it came from this idea. If you buy a camera today, it won't come with a book, it'll come with a PDF. And the PDF will probably have 800 pages with probably 10,000 instructions. I'm making this up slightly, but probably not exaggerating that much about this mode and that mode. You're not going to read it all. But when we're born, we don't come out with a PDF as far as I'm aware. I did deliver babies as a medical student and I didn't see a PDF or a memory stick come out. Out you come. And unlike the rest of the animal kingdom, we're a bit different. We're definitely part of We're separate from nature, we're nature. But we are a bit different from the rest of the animal kingdom, given what we can do and what we've done, good and bad. And I think that something's been lost in terms of community over the last few hundred years, across the world really, not every community, in terms of the passing on of knowledge of what it is to be human. I think we've lost the plot a bit. So I think it's okay to admit that and think, well, what are the qualities we need to be human? And what does being human mean? The 4 suits then got shifted, and over a lot of iteration, over a year of work, they're now available to buy. And we don't make money from them, I can assure you. We've lost tons of money, which is fine. It's absolutely fine. And the website is free to use. But basically, the hearts are how you orientate yourself. Where am I today? Do I feel centered? Do I feel hunted? Do I feel frozen with fear? Where am I at? What kind of season is it for me? And then the spades are how I resource myself. How do I sleep well? How do I eat well? How do I nourish myself? How do I rest? And then the diamonds are about the difficulties we encounter in ourselves. And the clubs are the difficulties we encounter in the other, because we all have challenges when we meet the other. And I don't just mean the other, someone we don't know, but even the other that we might quite like, friends, partners, family. And each card, can be used just as playing cards, or there are pictures on the cards which we spent hours arguing about. So you might say, oh, there's a fox and a rabbit or something, but I can tell you the meaning of them was argued about for hours, and we had a lot of fun about that. There are big words on the cards. There are little words around the edge of each card. And then on the website, there's a page for each card with lots more detail. So it ties into what I said earlier about a layered approach, where, absolutely, if you have diabetes and you come in DK, I must know your blood glucose. I must know, you do a blood gas and all the rest of it. But I soon need to know something about you and why this happened to stop it happening again. Because if I just treat the numbers, you'll be back in a month because you're actually very unhappy and you are unconsciously not taking insulin or whatever, I don't know. So the cards are a layered approach to self-discovery, really, to be human. And we're really excited to have done this. And we're working with psychologists and we're working with other people. And, they're beginning to gently spread their way out. And we share them with some medical students as well. So, yeah, it's an exciting project. But I think it comes later because, I'll be really straight with you now. And, you can really condemn me for this. If you said, Yamina, as a first-year medical student, well, I'm going to do the cards, I'd say, well, okay, of course you can. And it's not that you haven't got something to offer. You've got, I'm sure, tons of things to offer. Look what you're doing. You're taking your time to this podcast and it'll be really successful and well done. If you said I'm going to use my years of experience, I'd say, well, okay, maybe just wait a little bit to have a bit more experience. So this is not about being rude about you being in your 20s and me being a lot older. I think the facets come, the cracks in the skin come, the interest and the wrinkles come with a bit more experience. And there's nothing wrong with that. So get the experience.
I think that's such a beautiful place for us to end with a bit of hope for the future. So unfortunately, that's all that we have time for this episode. But it was such a thought-provoking conversation. I hope all of us agree. A lot of us to think over following recording and hopefully for our listeners listening. A huge thank you again to Dr. Lewis for his insight, his experience and his passion for supporting young people. We hope you enjoyed yourself being on the podcast as well.
Very much. Thank you so much.
So many good takeaways from what you've said. I'm sure within an hour of just a lot of things to think about. Like me and Yamina ourselves, we've been quite stumped here and there. I think one of the things that stumped both of us was that very concept of the body and mind. And as a clinical medical student, this is my first year in clinical medicine as well, I also noticed that a lot of us are just super, super stressed about getting the numbers right, treating the physical, which is definitely not a bad thing. But it does mean that we spend a little bit less time on really thinking about this layered approach that you were talking about and thinking of the patient as one person is something that I really do want to do better and better throughout my practice. So I'm really excited to take that in and bring that forward in my practice.
It's lovely to meet you both. Really enjoyed talking with you. Thank you so much.
Oh, you too. So to our listeners, if you're a medical student interested in adolescent and paediatric psychiatry, or just want to be better at supporting your younger future patients, we hope that this episode gave you some food for thought, and we'd love to hear your thoughts and feedback via Spotify or Instagram. If you like what you heard, make sure you're following at UCL MedSoc Peds on Instagram for updates on when episodes will be released. an opportunity to ask questions in future episodes, to rate this and please make sure to rate this episode on Spotify and share.
That's all. Thank you so much for listening to Teddy Talks, and see you guys next time.